Clavicle is a S-shaped bone. The lateral 1/3 is concave anteriorly, and the medial 2/3 is convex anteriorly. The lateral 1/3 is flat. The medial 1/3, 2/3 is triangular. So, if this is a triangle, it has basically 3 borders. So, the inferior border starts from here. As it reaches the medial side, it divides into a lateral and a medial portion, and it encloses a groove which is called as the subclavian groove. Now the clavicle articulates with the sternum on the medial side. So this is the notch of the manubrium sterni for the clavicle. Then there is a suprasternal notch, and then there is a notch for the rib, and finally the manubrium sterni ends. So here you will find the insertion of the rib. So from inside to outside, the lower end of the sternal notch attaches to the upper surface of the clavicle by what is called as the meniscus. This prevents the upward translation of the clavicle. Outside this is attached the capsule of the sternoclavicular joint. So this is the capsule. When this capsule is strengthened by the anterior and posterior sternoclavicular ligament, then there is a ligament which attaches this clavicle to the rib, which is called as the costoclavicular ligament, and therefore this costoclavicular ligament and the meniscus prevents the upward migration of the medial end of the clavicle and subluxation and dislocation of the sternoclavicular joint. So meniscus, capsule, anterior-posterior sternoclavicular ligament, costoclavicular ligament, and one ligament which goes to the other clavicle, which is called as the interclavicular ligament. So this is what forms the sternoclavicular joint. Then this inferior border here ends in the tubercle. It ends in the tubercle here, which is called as the conoid tubercle. And from there, the inferior border would go towards the anterolateral angle on the inferior surface of the lateral 1/3 of the clavicle. Now, parallel to this line which is on the inferior surface of the clavicle, which is directed anteriorly and externally, therefore it is called a trapezoid line, anterior and external AE. So this is trapezoid line. There is the coracoid process of the scapula. This is the suprascapular notch. And here is the supraglenoid tubercle and the beginning of the glenoid cavity. And the coracoid process, which is like a bent finger directed anteriorly and externally, is connected to the trapezoid line by a coracoclavicular ligament, this being the trapezoid part and this being the conoid part of the coracoclavicular ligament. Now, the lateral end articulates with the acromion process. This acromion process would be directed towards the posterior surface of the scapula. So this is the acromion process, and here you have the acromioclavicular capsule. But this acromioclavicular capsule is not strong enough to prevent a subluxation of the acromioclavicular joint, where this end of the clavicle must move up in relation to the acromion. That is basically prevented by an intact coracoclavicular ligament. Also, a fracture of the clavicle here, this fragment is free to migrate up, but a fracture of the clavicle here, since the coracoclavicular ligament is attached to the proximal fragment, it doesn't displace so much. So this is the ligamentous and articular attachment of the clavicle. Now we will move the muscle and facial attachment. So here we take the brown color. On the posterior border of the lateral third of clavicle is attached a muscle which is the trapezius. On the posterior border, on the lateral side, is attached a muscle which is called as the sternocleidomastoid. So this is the clavicular head of the sternocleidomastoid. So now the deep fascia, which is basically engulfing the trapezius, will go like this and engulf the sternocleidomastoid. So this deep fascia is attached to the posterior border of the clavicle between the sternomastoid and the trapezius. This deep fascia would go round the clavicle, will engulf the clavicle, merge with its periosteum, and we'll make another muscle which is the pectoralis minor, and this pectoralis minor starts from the coracoid and goes towards the rib. So this is the pectoralis minor. This deep fascia, which winds round the clavicle, attaches from the inferior border. It attaches to the superior border of pectoralis minor, winds round the pectoralis minor and becomes the suspensory ligament of the axilla. So the suspensory ligament of the axilla would come like this and will hold the thoracic deep fascia going from the chest into the arm. This fascia connecting the inferior border of the clavicle to the pectoralis minor is called as clavipectoral fascia, and if we extend it laterally, you'll see that it gets continuous with the conoid ligament. This clavipectoral fascia is pierced by four structures: the cephalic vein, the thoracoacromion artery, the lateral pectoral nerve, and the lymphatic, which spreads the cancer from the breast to the axillary lymph nodes. So this lymphatic is from the axillary tail of Spence. So these are the four structures that pierce the clavipectoral fascia, and you must know the name of these four structures because that's very frequently asked. Then, from the inferior surface of the medial two-thirds of the clavicle is divided by the inferior border into an antero-inferior and a postero-inferior region, and from the antero-inferior region covering all of this, right from here, and then the sternum, is a big muscle which we'll call as pectoralis major. So the pectoralis major is from the medial two-thirds and from the lateral one-third, and from the acromion and from the spinous scapula behind this is a huge muscle which is called as deltoid. So the groove between the pectoralis major and the deltoid is separated by the cephalic vein. We'll make it this way. The cephalic vein which pierces the clavipectoral fascia. And you'll remember that three other structures piercing the clavipectoral fascia are the cephalic vein, the thoracoacromion artery, the lateral pectoral nerve, and lymphatics from the axillary tail of Spence. So this completes the final muscle which is attached from the sternum to the subclavius groove is the subclavius. So here you will have the subclavius muscle. So what do we want to know about the clavicle? We want to know that clavicle is an S-shaped bone. It has got a medial two-thirds and a lateral one-third. The medial two-thirds is triangular. This is flat. So this is cancellous This is cortical. It has got a posterior border, an anterior border, and an inferior border. The inferior border has got a groove in the medial side, which is the subclavius groove. Posterior border gives attachment to trapezius, general investing layer of the deep fascia of neck, and clavicular head of sternomastoid. The anterior gives attachment to pectoralis major and deltoid. The inferior to clavipectoral fascia, which is pierced by cephalic vein, thoracoacromion artery, lateral pectoral nerve, and lymphatics. And on the subclavius groove is attached the subclavius muscle. The lateral 1/3, which is flat, has got an inferior surface and a superior surface. Nothing on the superior surface, but the inferior surface you have the trapezoid line on which is attached the coracoclavicular ligament. Then medially the clavicle articulates. So if we talk of the articulations, so medially it articulates with the sternum, forming the sternoclavicular joint, where you have to remember the meniscus, the capsule, the anterior and posterior sternoclavicular ligaments, and the costoclavicular and interclavicular ligaments. Then the second articulation is acromioclavicular joint, which is supported by the coracoclavicular ligament. Now, this clavicle can fracture because of fall on an outstretched hand. The usual site is junction of lateral 1/3 and medial 2/3. Why? Because this is flat, this is triangular. This is the junction of the two ossific nuclei. It is weight transmitting and weight bearing. So this is why the fracture occurs at this junction. Then what is the displacement? The distal fragment will go downwards, forwards and medially. Downwards, forward and medially in relation to the proximal fragment. And this displacement is because of the pull of the pectoralis major muscle. Okay, so to reduce this, you will have to tie a figure of 8 bandage. Basically, if you want to classify this fracture, the fracture of the clavicle that occurs, this is the coracoid, that occurs medial to the attachment of the coracoclavicular ligament, this can migrate upwards. But if the fracture occurs where the coracoclavicular ligament is attached to the medial fragment, then this will not prevent upward migration of the medial fragment. Then why you treat it by figure of 8 bandage. Complication, malunion. If you cannot reduce or retain by a figure of 8 bandage, then you open reduce and internally fix by a plate. But this will leave a scar. So this finishes the clavicle.